Hey everyone, this is my case study. My name is Kelly Young-Walter, and I'm a women's health major at this university, University of Missouri St. Louis, and this is for diagnostic reasoning, Module 7. Let's get into it. All right, Alexis Garcia is a 23-year-old Hispanic female who is a student at the university completing her master's. She's originally from Chicago, Illinois, living in the dorm at the university until December because that's when she'll graduate. Between classes, she is stopping by the healthcare clinic today at the university because there's issues down there. When walking, she has a grimace on her face, stating, "Walking irritates there, and when I pee, it burns." She's appropriately dressed for the weather and appropriately addressing her concerns today at the clinic with appropriate speech. So history of present illness. So Alexis Garcia presents in the clinic today for painful urination. She states, "It's getting so bad it hurts to walk. I woke up feeling like I have the flu, and it burns really bad when I pee." She noticed these signs 2 days ago and noticed she had unprotected sex about 2 weeks ago with a guy. Alexis tried self-treating over the counter for medications with urinary tract infection, but symptoms are progressively getting worse for her. So, review of symptoms, I'm asking her questions. The main things I've noted, the most relevant, are positive for chills and fatigue, and then she's positive for difficulty urinating, dysuria, painful urination, and some vaginal pain. Then when I get into the physical exam, these are her vital signs. Her heart rate is a bit elevated. I can tell she is in pain. When I ask about her pain, it's 9 out of 10, and she stays in the perineum region. Walking and urinating makes it way worse, and then nothing makes it better. And she describes the pain as very sharp and obviously a burning sensation with or without urine. So with her physical exam, and since her chief complaint is more noted in the genitourinary system, therefore that's my focus for my physical exam. So I noticed the labia majora and minora, there's multiple tender hollow ulcerations bilaterally on both of the folds with a moist appearance of each ulceration, and there's multiple. I also noticed there's a pattern. It's like a serpent snake-like pattern on the labias or on the vulva, and there's a red halo around each ulceration. Because of how painful it was, just to do an inspection on her, get her up in stirrups, she denied the bimanual internal inspection and performing a speculum to kind of look at the vaginal walls and the cervix. This is what I'm visualizing on her physical exam. So when she first walked into the clinic with chief complaints of painful urination and that she had unprotected sex 2 weeks ago, automatically we'll run a UA and a urine HCG. This is just a point of care test that we can just do in the clinic. So the UA results came back negative. The urine HCG also came back negative. So that makes me think, okay, I can get rid of the UTI diagnosis. The UA came back negative. Let's see. None of the over-the-counter medications for her UTI, suspected UTI, were helping. The pain was progressively getting worse. The ulcerations, because of those ulcerations that she had no idea that she had, it makes sense why the urine was burning those ulcerations, and then she's stating that it hurts to pee really bad and it hurts to walk. With the viral culture, so with this, viral cultures are useful in primary episodes when culture is sensitive is 80%, but less useful in recurrent episodes. So this is her first time ever stating she's had any type of ulcers, lesions down there. I'm kind of already thinking this is HSV 2 of the genitalia. So with the culture test, you should only be performed within 24 hours of the appearance of that herpes-specific blister, and when the blisters are fluid-filled. If it's crusted over, the doctor may not be able to collect enough fluid. We're in the active phase, and it's important to get enough fluid so then we can actually culture the virus to be 100% that it is herpes simplex 1 virus. But providers are able just to visualize and have those key presentations and clinical symptoms, and they're able to diagnose HSV2 without any diagnostic tools. So we have the HGG antibody test as well, and this is more for previous exposure. This is not, you cannot do this with testing for present virus. So about 3 weeks, it's about 50% accurate, and then 12 weeks go by, it's more like 90% accurate, and the results will more be positive. But the serologies, the serum of AGG and PCR are not gold standard for right now, right here, viral culture or PCR swab. That is preferred. And then also in the clinic, we do have the Tisink smear. This will just kind of smear, get the fluid-filled pus, smear it on a slide, and then stain it, and then through the microscope we're looking for giant cells, multinuclear cells of only the nuclei, and ground glass appearance. So again, this is what I'm looking at, this is what she has, and the diagnosis of genital herpes is often made clinically by a simple inspection. Like I said, the golden tool is a viral culture. Positive results are available 16 hours to 7 days. Like I said, her UA was negative for everything, Luke's, Knight's, blood. These are the specific ones we look at, noting because they're related to a UTI. A year, like I said, it only had one line, so that means negative. And then the Tizing smear, we aren't going to use that today because it's less sensitive and less specific. And I could just use my visualization skills as a provider and note that it is HSV2. So here are also the other differential diagnoses I was thinking. So we already ruled out UTI. Next would be the concroid. So this was painful vestibules, foul smelling exudate, which we did not have. Urinating can be painful. Okay, she did have that. And a burning sensation from open lesions. Yep, we definitely did have that. But, in the pattern, there is no snake-like pattern. There's no halo around each multiple small lesion. So it makes me think the concroid and the parameters describing concroids, they do not align with HSV2, which we'll get into next slide. The Candida albicans yeast, so there's itching, vagina and vulva, burning sensation, there's a rash, thick, white, odor-free vaginal discharge. This patient did not have any vaginal discharge. She did not have any itching. If anything, she was in a lot of pain. With yeast, though, it's commonly misdiagnosed as HSV, or HSV is misdiagnosed as yeast because of how intense the itching is. Women will itch the perineum and it will create lesions and ulcerations, making it look like HSV. So that's important to note, the true signs and symptoms and the clinical presentation between HSV2 and Candida albicans yeast. And then lastly, primary syphilis. So you get the flu-like symptoms like she had as well. The vulval pain, we were positive for that. The itching and discharge, we didn't have so much itching and discharge. The biggest thing to note for primary syphilis is typically one ulcer. But actually primary syphilis and HSV2 have been misdiagnosed quite frequently because it's one or the other. So this is HSV2. This is the clinical presentation like I told you about. The labia majora minor, there's multiple tender hollow ulcerations bilaterally with moist appearance for each ulcer. It's a serpent-like pattern. The vulva and red halo around each of the ulcers. Therefore, we're able just to diagnose her right then and there. It's HSV2. With this, there's the symptoms, of the whole body. So that explains her flu-like symptoms, particularly for the primary episode. So if this is the first episode, it's more common to see these flu-like symptoms. Acute urinary retention is also common. Symptoms of the vulvar pain, itching, and discharge from lesions peak between 7 and 11 days of the primary infection. This is her primary infection, and she's within these appropriate days at the clinic today. So that also goes into the parameters. The incubation period is 2 to 7 days. This is the primary lesions or the vesicles, multiple lesions, about 1 to 2 millimeters in diameters, like we can see in the image. The edges are erythemic, a red halo around it, superficial depth. There's some serousness or fluid-like coming from the ulcerations, and pain is very common. Patients may experience multiple ulcers, crops for 2 to 6 weeks when that does have some scarring, but then the viral shedding may occur 2 to 3 weeks. Important to know with HSV. So it is more common than we think. So the general population is not indicated to test with HSV 1 and 2 when you're checking for STIs because 80% of infected individuals are unaware that they are infected and they're asymptomatic. Shedding leads to transmission, may occur as frequently as every 5 days. So the population of the world, 80% have HSV 1 and or 2. It's really common, but it's asymptomatic, some of the symptoms. Someone may never show symptoms for this virus. Nationwide, 11.9% of people age 14 to 49 have HSV2, more common between non-Hispanic blacks than non-Hispanic whites, and 60% of primary genital infections are caused by HSV2, and yes, HSV1 can cause genital herpes, but that's only 40%. So, treatment and education with HSV2. So first-line treatment for primary episodes, because this is what our patient has. She's a primary infection. It would be different. We'd treat her differently if she is reoccurring infection. This is her first time. So we have acyclovir, valacyclovir, or famciclovir. Precautions with this: absence of active lesions due to asymptomatic shedding of the virus. Therefore, practicing safe sex with condoms can prevent infections. But some lesions do develop outside the tissue covering the condom. Constant use of condom wear is highly recommended, but also mandatory if you want to stop HSV spread. A recurrence is common and suppressive therapy may need to be started. And then herpes simplex virus is non-curable. It will either be an active phase or a latent phase or a dormant phase. And sometimes you're asymptomatic, but yet you can still be spreading the virus. And then next is